Hi, everybody. We still have a few minutes. Santiago, I already see that you're on. Great. Thank you for joining us here. I hope that everybody's safe and okay. So today we will discuss two papers, and before the others are joining, question to you, Santiago, do you want to go first, or do you want me to first go through that paper from Eduardo Marban and Dr. Akmarov on kind of a COVID review?
It's up to you, totally up to you, whatever you think is best.
So then if you don't mind, because some of what we are discussing may be related, so what we will learn from the first paper may be related to what we then will learn from you. So then I would go first, but I'll make sure it will only take about 10 minutes for me to walk through that paper.
Sounds good.
Great. And we'll wait for a few minutes. Usually most of the people just call in right at the time or a minute before. So where are you exactly? You're in Minneapolis now?
I'm in Minneapolis. I think we have a mutual friend, Joao Cavalcanti. I'm in the same group as Joao at Minneapolis Heart Institute.
Yeah, no, say hi from me. So it's always good to interact with him. Yeah. And how's the situation in Minneapolis now?
Well, we're not at the epicenter of this. We have seen cases. Luckily, we started with social distancing early on in March, and so far we haven't really seen lots of cases. I think it's over 2,000 cases and about 100 deaths in the state of Minnesota as of today. Mm-hmm. So it has not been overwhelming for the healthcare system.
Mm-hmm. Oh, good. That's good. Yeah, in Canada, it's a similar situation, probably because the measures came in rather early. The capacity of ICU beds is currently, or of COVID beds, it's at about a 75–80%. Mm-hmm. And we're already at the plateau, so it doesn't look like it's going to crash like in some other countries. So that's certainly good. Yeah, and I'm currently actually in Germany, and here it's also similar. People were pretty well prepared, and because lots of people could go off work without having to face any issues. So lots of people stayed home when they had the first symptoms. That helped, and then also the restrictions. Also, that was the other part. Was important were implemented and people were behaving well, and so that's why we have a rather low number of deaths. That is also good. And do you also have a lot of restrictions of regarding how many people you actually are seeing as regular?
We all the outpatient procedure have been canceled, and across the state. That's us, everybody, and also the outpatient visits are now all virtual visits, teleconferences. So we're hoping to go back to the finance close to normal in May, but we still have significant deficiencies in testing. So
are you expecting things to go back to rather normal during May, or?
We are. Everything is contingent upon availability of testing. So if we could test more, I think we will be probably back to normal in May. But the state now, Minnesota decided to do their own testing. Mayo and the university are supporting that. So we're ramping up capability.
Yeah. Okay, so I think we're at the half hour now. So at 5:30 here in Europe, or 11:30. So I will share my screen, and I hope everybody can see it. So welcome to today's CMR Journal Club that now since almost a month has been turned to a cardiac COVID special. And today we will discuss two papers, both not specifically imaging in a narrower sense, but both with a lot of relationship and relevance to imaging. The first one I wanted to highlight here, and Eduardo Marban is too busy, he cannot join us today, but I will walk us through that paper because I think it's the most comprehensive review, the most solid, and even though I will not go through all the detail, I recommend this paper, and it's up for download from the Journal Club's archive, and it was published in Circulation Research, and it's simply called COVID-19 and the Heart, and it kind of summarizes where we are currently with the knowledge about how the disease affects the heart. So the highlights of that are that, first of all, what is probably known to most of us, I will not go through the basics. Yeah, it's at that time, there were more than, so that's from April 3rd. So then now the numbers are not that accurate anymore. In the meantime, we have 170,000 deaths. Just to put that in perspective, the swine flu 2008-9 had 200,000 deaths. So we may up with a similar overall number, at least for now, but the longer term is what we will have to see. And there has been a lot of interest. And to me, very impressive was the speed of with which the research picked up, papers were published, and also fast-tracked. So it seems that the research around COVID was in kind of in a different league in terms of the speed of development. So that is certainly a positive thing, and may be a precedence for future developments, even outside of pandemics. So with respect to the heart, overall, it is important to keep in mind that while most the disease severity has been related to the so-called severe acute respiratory syndrome, and even the virus is called like that, and though we know that most of the patients who die from COVID-19 die with what looks like an ARDS, but I say specifically it looks like an ARDS because there are actually some reports that it may not be a standard ARDS. And what we also know, a lot of the deaths are actually related to cardiovascular disease. That doesn't mean that COVID is a cardiovascular issue by itself, but it means that the cardiovascular system is strained massively by that. So overall, the case fatality rate is not very high in COVID-19, but it is very high, or it is relatively high in elderly patients and patients with cardiovascular risk factors. So if we talk about the mechanisms, and that is also important in order to understand what we see with imaging and also what we find clinically, it's, as I always tell my students, it's mostly about understanding pathophysiology, and for imaging, it's visualizing pathophysiology. That helps us more than anything else. So what we see is that there's an early infection phase in COVID, where it's more like any standard viral infection. There is a fever, malaise, fatigue, some myalgia. So there's a kind of a first immune response of the body saying, hey, there's something wrong. And the first line response. And then this response can also come with some collateral tissue injury that comes with, say the stuffy nose, so the vasodilation, endothelial permeability, and all that. But then this can then evolve to a more severe or an overly severe immune response that, especially then in younger males, we have to say, at least statistically more so, lead to more severe pulmonary damage and eventually also cardiovascular stress. And this is what has been referred to as the cytokine storm. Now, what does that mean? So we have a systemic toxicity. We may also have some direct leukocyte infection. and probably related to a relative lack of regulatory T cells in a more advanced stage of the disease. We have this so-called cytokine storm where certain molecules are associated, molecules like interleukin, TNF-alpha, interferons, and such are associated with bad outcomes and with also the clinical severity of the disease. So non-survivors exhibited higher levels of all these molecules. And so while you have then an initial response of the body to which is local, the overall effect then can, of course, also involve others. So I'll just quickly jump to the figure, so you not also always have to stare at a text. So here you can see during the first 5 days, the viral response. So this is not the dangerous one, but then stage 2, where the lungs are infected, you can already have abnormal CT scans or chest X-rays. And then we have stage 3, which is then a more severe response of the entire body that can then severely affect the lungs and the heart. The heart can be affected directly or indirectly. So there is evidence, although it's not very strong, I have to say, for direct infection of the heart. In fact, as the authors also state here, viral genome can be found in cardiomyocytes, but just the genome. So virus itself has not been found in cardiomyocytes. So far we do not have evidence for direct infection of the heart. But if the fact that we found viral genome means that the inflammation and the virus has entered cells that eventually also ended up in heart tissue, and that the heart itself was directly affected and not just indirectly through inflammatory responses that lead to increased overall stress, or secondary to respiratory failure with an increased pressure on the right ventricle or hypoxemia. So the issues we have with the heart are mostly clinically arrhythmias, acute coronary syndromes, and heart failure. However, the mechanisms for that also are clear once we have understood the pathophysiology. During the first phase, it's basically general inflammation, but during the cytokine storm, it's actually then cellular toxicity that leads to or could lead to necrosis, that is something, however, where we are not entirely sure. I'll skip the part on ACE, so angiotensin converting enzyme 2. Although it's very interesting and it's very important, it's not so much related to imaging, but the nutshell is that currently we are not entirely sure whether ACE inhibitors are helpful or not, or maybe even counterproductive. The data point more towards being helpful, and because the ACE2, they are, on one hand, they can modulate their immune response and so are protective. On the other hand, they are also the entry for the virus. So this is a kind of a double-edged sword, and we'll have to understand more. But now coming back to the cardiac involvement, we know that that myocardial damage and heart failure contributed to 40% of deaths. So that is quite a lot. These are early Chinese data, but I don't think that this will be much different in other populations. And as I mentioned before, the mortality risk was significantly related to the classical cardiovascular risk factors, age, diabetes, but also then, of course, to chronic, especially chronic obstructive lung disease. That is it's not yet entirely clear. Of course, one might argue that patients who have cardiac disease anyways, that they have a higher likelihood of then succumbing to an additional stress, but that is maybe not the entire and then there also be the notion that the more people are dying on the wait list for the cath lab, for example, than to that. But this is a different discussion. We'll have that with Santiago in a few minutes. So when we look at autopsies, and there are not many data out there, as I said, there are no data demonstrating the presence of the virus itself, but the viral genome has been found in 35% of these, notably with decreased levels of ACE2, which is basically the protective part, and increased hypertrophy. Now, this has also been associated with high blood pressure, and that's, to me, a very interesting part. Hypertension has been, so I'm jumping to this one here, has been strongly associated with disease. And interestingly, patients with critical courses of the disease, they tend to have more higher blood pressure than lower, which is totally counterintuitive. We would think, hey, if this is a very severe inflammatory response, then you would have a rather low blood pressure. But here we don't see that. So what does that mean? It could, for example, mean that patients with high blood pressure and an increased vascular permeability that would be related to the ACE2, then have more edema and then get into cardiovascular problems, because more edema could then end up with heart failure with preserved ejection fraction. That's what we have done in our research, showing that patients with HFpEF have a higher water content. So this is a very interesting aspect, and we will have to see what cardiac MR will show. So far, the few case reports we have, they are consistent with significant edema, widespread edema. So that would corroborate that hypothesis, but we will have to see more data. Then we have also, of course, acute coronary syndromes, and I would be also interested in Santiago's pick on that. I didn't see in the data that we have a massive increase, although technically we should see more, because everything COVID does also would increase the risk for ischemic events, the inflammation alone, endothelial dysfunction and all that. But so far it has not led to a massive increase of cases with acute coronary syndrome. In fact, what was observed was a kind of initially it looked like a magic decrease of classical acute coronary syndrome. So I will not comment on the therapeutics and all that, but I recommend this paper. Otherwise, if you want to look up some of the mechanisms here, and also how certain cells are involved in that, and how certain therapeutics, although we do not necessarily yet have any therapeutic where we can be sure that it will help. But what it means for myocarditis, to summarize, for imaging, what it means to summarize that if we deal with myocardial injury as evidenced by an increased troponin and clinical symptoms that are consistent with acute myocardial injury, then it is most likely ischemic or non-ischemic, ischemic as in a classical acute coronary syndrome, or non-ischemic as myocarditis. And what we do not know yet what it means long-term, but there are some indicators that there may be long-term sequelae with myocardial injury. So we will probably, even after the pandemic, although it may come back anyways, but even once there are no new acute phases of such a pandemic, we will probably deal with long-term effects of disease. Any comments are welcome. Otherwise, I would then ask Santiago Garcia from the Minneapolis Heart Institute. Thank you very much for coming to share his screen, if possible, and then walk us through the PDF of his paper that was recently published that I found extremely interesting, that is called Reduction in ST segment elevation cardiac cath lab activations in the United States during the COVID-19 pandemic. So it was published in JACC, and Santiago, thank you very much for joining. And I don't know whether you can share your screen. You have that green button
yes.
on the bottom of the screen?
Yep.
If not, I can also share. And oh yeah, there you go. So it's now, now we can share your screen. Yeah. And
thank you.
Yeah.
I'll share two things. I'll share the paper first, and then I'll show you a couple of slides that I think are helpful to understand. So this is actually a research letter. It's not a full manuscript, but we wanted to get the data out so people understand. There's been a lot of chat in social media about the missing STEMIs. We're just not seeing enough STEMIs. And this was an issue because everyone was preparing with PPE and the shortages of PPE to receive these COVID patients. We changed the processes. I think most centers in the US move away from having patients present to the cath lab directly, from ambulances and helicopters, to have the emergency department serves as a triage unit where patients will be assessed for COVID symptoms and then go to the cath lab. And we were all sitting waiting for these patients that never arrived. And so what we did is we asked 9 high-volume primary PCI centers in the US to give us data about cath lab activations. And we decided to have 2 periods. We call it, in a biblical reference, AC and BC, after COVID and before COVID. The before COVID period, we decided that we're going to be looking at number of cath lab activations per month per site, starting in January 2019 until the end of February 2020, so 14 months. And even though the first case was reported in the US in the last week in January of 2020, we didn't really take this disease very seriously until March. That's when most states started with social distancing measures, and hospitals sent a message to the community that we're not doing outpatient procedures, all visitors are not allowed in hospitals anymore, etc. So we started March 1st as after COVID period. And that was a sort of an arbitrary definition. And we asked all these 9 centers to submit their data for STEMI volumes, and I'm gonna show you what we found. So these are centers that are representative of the US. You may remember the first case was reported on the West Coast in Seattle. And we had 1 center there in Seattle. We had 3 or 4 centers in the East Coast, including New York City, which is at the epicenter of the COVID pandemic in the US. New York has approximately 50% of the cases in the United States are located in New York. 2 centers in Boston, which is also affected by this, and then 4 centers in the Midwest. This is part of what we call the Midwest STEMI Consortium, including us. In Minneapolis, Minnesota, we have a center in Iowa, Illinois, and Ohio. And as shown here, this is the number of STEMI activations per month, and all the centers included. And we can see in blue is the year 2019, in red you see the year 2020, and the after COVID period, which again is only 1 month, you can see a significant decline, only 138 activations. There has been no other month with activations that low. Even February 2019, which had only 27 days, had more STEMIs that March of 2020, 181 versus 138. So overall, this is a concerning signal, a 38% unexpected reduction in STEMIs. And let me just switch to this other presentation. Can you see the slides? Okay. This is the data for each individual center. This is not included in the letter. Hopefully will be part of the manuscript. We have a follow-up manuscript including data from April and more sites. But all the centers have actually shown declines in the month of March. We think that the centers that are located in states with very high COVID prevalence will be more affected by this. And as you mentioned, Matthias, this is not something that we expected. In fact, there is data from influenza that the number of STEMs during an influenza season tend to increase, and there is biological reasons for that, as you alluded to in your discussion. So this is counterintuitive. The mechanism, we think, is that patients are having their STEMIs at home. This is data from New York, published in The Economist. There has been an 800% increase in 911 calls and cardiac arrest at home in March. And this has continued in April. I think patients are afraid of the hospital systems. They don't want to come to the hospitals, perhaps out of fear of contracting COVID-19, and that they're having their heart attacks at home. Another potential explanation is that many of these patients perhaps think they have COVID. And the one thing that we've been telling them to do is to self-isolate at home. And we believe that many of these patients actually may have acute cardiovascular conditions. This is just one case from a friend of mine in New York, and we have seen two. I don't know if you can see the video, but this is essentially a lady that waited 2 weeks with chest pain and shortness of breath, thinking she had COVID. When admitted to the hospital, she ruled out ×2 for COVID, was taken to the cath lab, and a 100% thrombotic occlusion in the mid-RCA and a ruptured papillary muscle with severe MR and ended up in the OR. And we have seen in the last 2 weeks, 2 cases like that, mechanical complications due to lack of reperfusion. Both patients presented with BSDs, and they didn't do well. And so I think we have to be mindful as we roll out these directives to send a message to patients that we're still open for business, that the patients should try to avoid self-diagnosis and call 911 and try to establish care with their primary cardiologist when there are symptoms like this. No, Matthias, if you want to open it up for discussion, I can stop here.
No, thank you very much. That was extremely interesting, and you already answered of course, the first question that was very obvious from my end. What do you think is the main reason? And the data from New York strongly indicate that it is indeed a collateral damage, that it's just not visible, or has not been visible before, that people stay at home and they die, and they do not count as COVID deaths, but they also don't go to the cath lab. And so and there was actually a New York Times article, I think today, where this problem was also addressed. There is an overall increase of the overall mortality that exceeds what we would see as a statistical fluke, and that is quite likely related to deaths happening at home, not counting necessarily as COVID deaths, but still. We definitely see an increase of overall mortality in pretty much all the countries that have been affected by COVID-19. So is your point then? I mean, it's what should we do? Should we put pressure wherever we can on being more open? So our cardiology department, for example, in Montreal, we are discussing this almost every day. At what time is it right to open the cath lab further? There's, on one side, we see the need, and most of the interventional cardiologists actually say, yes, we should do that, because I see my patients do really badly. They need their intervention, and it's not just coronary, it's also the TAVIs and other procedures. And then there's, on the other hand, there's a concern, hey, if we open the floodgates here, we maybe our staff is at risk, and then if the staff is infected, then we'll just transfer. So what's your bottom line of all that discussion?
My bottom line is we need rapid testing. I think we need to be able to know who comes to the cath lab as to whether they are COVID positive or not. It is a standard of care, at least in the US, to test every single patient for MRSA. Once we have testing available, I think we should do the same for COVID. As you know, everyone is in this category of PUI, patient, a person under investigation until we know. And sometimes it takes a week to know if they are COVID positive or not. And in the meantime, these patients are not getting the test they need, or if they do get the test they need, it's an incredible amount of PPE that perhaps is wasted and not needed. So I think the reopening of the hospital system is going to be very closely linked to the testing part. As you know, Abbott Vascular has developed a testing that hopefully it will give us an answer within a few hours. I don't know how available it is in the country yet, but that's where we need to go. We need to go to a model where we're not blind anymore, and we know exactly who has the disease and who doesn't. I think we are at risk here of losing 2 decades of progress in STEMI care. We've been telling patients to call when they have symptoms, to present to the emergency department early on. And we have instances too where the emergency departments are misdiagnosing these STEMIs because no one is doing EKGs. They're not getting close to the patients for fear of contracting COVID. And that's something that we also need to change. The mortality, as you know, this is, if you have a minute, this is another paper that we didn't publish. This came from New York. Can you see the slides?
Yeah.
So this is the early experience. It was published a few days ago in the New England Journal of Medicine. 18 patients with ST segment elevation, myocardial infarction, and COVID. And they took to the cath lab about 50% of those patients, and somehow they broke them down in 2 categories, MI and non-coronary myocardial injury. And I just want to point out a few things. Very few of these patients had chest pain. Only 33% of these patients had chest pain. The majority of these patients had cough and fever, and many of them were intubated. Now, 50% of these patients presented with ST elevation when they came to the hospital. But the other 50%, they developed ST elevations in the hospital phase with a median time of about 6 days. So these are patients that are in the ICU and they're very sick, and they, in that context, develop ST segment elevation. Now, when you look at their strategies, in orange, you see the ones that they categorize as non-coronary myocardial injury. In blue are the STEMIs. You can see this is not the typical STEMI data. This is a 72% mortality at 30 days. I don't think there is any other data set that will show such a high mortality for these patients. Of the patients that underwent angiography, about 50% of them, 2/3 had a coronary culprit. And of those patients, the majority, 5 out of 6, had a PCI. But you can see that the majority of these patients die, in particular in the non-coronary myocardial injury. And so the EKG, you have here one patient that had a culprit, another one that did not. It's very hard to distinguish these 2 subsets based on the EKG alone. And they reported data for troponin and D-dimer, and these are supposed to guide us. But as you would imagine, look at the numbers in orange. I mean, some of these patients have troponins in the 40s and 80s. This is not, I think, a troponin value that will reassure a cardiologist that this is not a coronary type 1 myocardial infarction. And there is a significant overlap between these 2 entities. Imaging can help. As you can see here, the majority of these patients with diffuse ST elevations and non-coronary culprits had lack of regional wall motion abnormalities, but the numbers are very small, and we need to learn more about this. So these are kind of the two sides of the coin. One is the real STEMIs that are not coming to the cath lab, and these STEMIs in the setting of COVID that do terribly, more than 70% mortality, no matter what we do. So I think we have a lot to learn about this disease. But in the meantime, it seems very prudent to at least send a message to the community of cardiovascular patients that if they have symptoms, whether it's shortness of breath, chest pain, or any other manifestation, they don't need to play doctor. They need to let us know and follow the usual pathways. Yeah.
Well, thank you very much for your insights here. We're already at the top of the hour, but and I try to be very protective of people's time, but I want to use a few minutes on some. First, I see that Dr. Akhmerov has joined. So I'm sorry I didn't see that right when we started. So you could have presented your paper. So welcome still, Dr. Akhmerov, calling in from the Cedar Sinai Medical Center. And then I want to, next week, we will have the next of our journal clubs, but they're very important changes. So now the CMR Journal Club, we teamed up with the JCMR Journal Club and the physics webinars. So there will be, these are all the Society for Cardiovascular MR Journal Clubs. And we will now be on every fourth Wednesday of the month. Next week, however, while we are already going for the Wednesday, it's next week is the last Wednesday of April. This will be another special on COVID, so we will have again 2 papers. So we will first discuss. I hope you can see my screen. This paper from Qing Deng, suspected myocardial injury in patient with COVID-19, evidence from frontline clinical observation in Wuhan. And then we will also have Enrico Ammirati, who wrote the editorial, who will then discuss that paper with us. He wrote the editorial in the International Journal of Cardiology. So there are some very interesting findings here. And I also wanted to point you to some other papers that have been published recently. This is very interesting by Gattinoni and others on some evidence that that actually the lung injury may not necessarily be ARDS, but more a thromboembolic event that happens on the small vessel level. So very interesting data here. Another interesting paper for you is the review called Myocardial Injury in the Era of High Sensitivity Cardiac Troponin Assays. It's not directly COVID, but I think it's important to what Santiago pointed out. And I want to also use that opportunity to stress the point for imaging. As you said, Santiago, imaging can play an important role, and, and I would not be myself if I would not strongly recommend to all those who have access to cardiac MR to make use of that. Cardiac MR, in cases where it's not entirely clear, can, if you have access to a cardiac MR with a protocol that takes less than half an hour, very significantly or very specifically differentiate ischemic from non-ischemic injury. Plus it gives you the severity of the tissue abnormalities. Plus it gives you left ventricular function, morphology, and volumes. So you have basically all the data you need. We're currently beginning a study together with the Cedar Sinai on a shortened cardiac MR protocol that also includes the lungs. So you have kind of a double rule out. So this is something that should be used because the CT cannot do that for the heart, but the MR can do it for both. And then there's here's another case report for just for you to look at. Also published, and these papers will also be up later today for download from our website. Again, Takotsubo here, but this is what I think is important to keep in mind. Takotsubo's main feature is edema, and in this case also it was myocardial edema. So there is a message here somewhere. Okay, with that, I want to thank you very much for your attention. So next Wednesday at 10 Eastern Standard Time, 4 p.m. in Europe, 3 p.m. in UK, and the other time zones will be on the website. We will have the last COVID-19 special of the CMR Journal Club. For that, I want to thank you. I hope everybody can stay safe in these days. Santiago and Dr. Akhmadov, thank you very much for joining, and all the best also for your work. Take care.
Thank you. Bye-bye.
Bye-bye.